включаю
Yes.
PowerPoint и выключаю TeamViewer, вы ОК нажмите, и потом переключитесь на презентацию и переключайте влево-вправо. У вас сейчас окошко TeamViewer выскочит, его просто закройте.
Ну все, его уже... Ага. Окей?
Окей, да.
Все, окей. На презентацию влево-вправо.
Да.
So, yes. Okay, спасибо. Thank you. Алло, good day. Today, if you hear me, please. Today, our lecture is colorectal cancer. Colorectal cancer, or cause or cancer of large intestine, is the term which unites two groups of tumors. The first, colon cancer in cecum ascending colon, transversum part of colon, descending part of colon, and sigmoid colon. The second part or second group is rectum cancer. Cancer of the anal canal of rectum, and the second is rectosigmoid corner and ample of the rectum. And all treatment of the patients with colorectal cancers depending on localization of the tumor, in which part of colon, or if it is rectum cancer, in anal part of colon or in rectosigmoid corner. It is very important to know localization. Epidemiology. Colorectal cancer is the third most common malignant tumor after breast and lung cancers in women and prostate and lung cancer in men. Incidence: highest rate in USA 29.6%, in Canada 22%, in Scotland 21 and 2%, from 100,000 population. Lowest rate in Japan, Africa, and Asia. 3 to 4% from per 100,000 population. Epidemiology: the incidence increased from 73 to 85, decreased through 95, and remained stable or increased slightly through 98. Death rate. In male, the death rates are highest in Denmark, behind 39 per 100,000 population. In female, the death rates are highest in New Zealand, behind 27 per 100,000 population. In Southeast Asia, the death rates are 22.7 in male and 20.2 per 100,000 population in female. The lowest death rates in male are noted in Peru, 2.8. In female, the lowest death rates are estimated in Peru to 3 per 100,000 population. 6. Up to age 50 years, the incidence of colorectal cancer up to age 50 years, the incidence of colorectal cancer is similar among men and women. However, after age 50 years, men have a higher incidence rate than women. Males and females are affected by bowel only equally. The male to female ratio for colon cancer is about 1:1. But the male to female ratio for rectal cancer is 1.5 to 1, more than female. Age. Mean age of colorectal cancer incidence is 62 years. Incidence rate begin to increase substantially during the 6th decade of life and continue to increase thereafter. Usually our indication in colorectal cancer to detect in very early stages, usually all people more than 45 years must undergo colonoscopy 1 time a year or erigoscopy to exclude if there are any tumors in colon. Mechanisms producing colon cancer. There are 3 basic pathogenic pathogenetic reasons of development of colorectal cancer. First, the action of carcinogens in food. Second, proliferative processes in intestine mucosa. And third is dysbacteriosis in colon. Mechanisms producing colon cancer. Non-known mechanism account for the causes of cancer in the proximal, or we told, if you remember in anatomy, proximal part of colon, or we can told right part of colon or right side of colon, including cecum, ascendens part of colon, lever angle of colon. We told about these parts, 3 parts: right side or proximal part of colon. Cancer of the distal part of colon, or we told left side, of colon, which including spleen angle, descendens part of colon, and sigmoid junction. And sigmoid part of colon, sigmoid junction, seems to be associated with the type and amount of fat consumed. There is some parallelism between the occurrence of rectal cancer and distal colon cancer. Distal colon cancer, as we told, sigmoid part of colon, sigmoid junction, descendens part of colon. A weak association possibly due to promoting element like bile acids. Some epidemiological studies have associated the intake of alcohol beverage to rectal cancer. It's associated rectal cancer with alcohol intake. Risk factors. Age after 50 years, familial polyposis coli, or we told Gardner's syndrome, Peutz-Jeghers syndrome, family cancer syndrome. Non-hereditary acquired disease, likely colon polyps, chronic ulcerative colitis, and Crohn's disease. Lack of vitamins A, C, and E, and dense vegetative fibers in diet. Asbestos workers, show workers, and machinists. Now, usually, the asbestos factors, asbestos workers, show workers, and machinists usually associated with rectum cancer. Usually associated with rectum cancer. More significantly, precancerous disease of bowel are family polyposis of intestine, Gardner's disease, non-specific ulcerative colitis, Crohn's disease, familial cancer syndrome. The precancerous disease of rectum are family polyposis of the intestine, Gardner's disease, villus polyps, non-specific ulcerative proctosigmoiditis. In comparison with other malignant tumors, large intestine cancer is characterized by some biological features. in all malignant tumors, in colorectal cancer, biological features is slower growth. The first. Next, later metastatic spread. Later spread into the adjacent organs. Depending here on localization of the tumor. For example, if the tumor localized in transversus part of colon, the first adjacent organs is stomach, pancreas, small bowel, for example. More frequent development of inflammatory complications. Histopathology. About 19% are present adenocarcinomas, malignant carcinoid, sarcomas, and lymphomas. In the anal canal of rectum, there are several different cells types with different biological behaviors, including squamous cell carcinomas, and glaucogenic carcinomas. Anal adenocarcinomas are rare. More than 19% in anal part of rectum is squamous cell carcinoma. And here is important, if you remember in our first lectures, that you must take biopsy because, for example, if it is anal cancer, anal part of rectum, and the histological investigation is squamous cell carcinoma, we will explain when we will discuss the treatment, but it's for you to remember that if it is squamous cell carcinoma, we can treat these patients by chemical, radiation, the type of treatments, combination, chemical, radiation treatment. This patient don't need surgical type of treatment. For example, if it is adenocarcinoma is less sensitive for chemical treatment or chemical drugs or radiation therapy, less sensitive. Squamous cell carcinoma more sensitive, and we can treat this patient without any surgery. Surgery. Site. %45 of cases occur distally in left colon. Yes, as we told, the site 45% in left part of colon, in left part, distally part. 40% in proximally part of colon, or we told, as just now we told about this, or we told right part of colon or proximally part, which including cecum, ascendens, and liver angle of colon. 15% only in transverse colon. Metastatic spread. No, here you must know anatomy, because the metastasis spreading through lymphatogeneously and hematogeneously. Most common is lymphatogeneously. You must know the blood supplying the part. Metastatic spread of large intestinal cancer may occur consequently in following lymphatic collectors. Epiploic nodes in subperitoneum layers of bowel wall, the first. Paracolic mesenteric lymph nodes. Intermediate nodes near the left intestinal artery. Principal nodes of mesenteric bases. Remember the blood supplying from mesenteric superior and lower part from mesenteric inferior. And if you remember in our lectures before, we discussed that when we do operation, we must do lymph dissection. Lymph dissection through the artery which blood supplying. We must remove all regional lymph nodes. Lymph dissection we must do. Low rectal and anal. What mean low rectal? Low rectal, it means, if you remember the same, the rectal divides to three parts: lower part, middle part, and upper part of rectum, or we told recta-sigmoid junction of rectum. Three parts for rectum, and anal part. Cancers tend to spread laterally to perianal nodes and may appear in inguinal nodes rather than in retroperitoneal nodes. Just in lower part of rectum, as we told, there are three parts. The rectum have three parts: upper part, middle part, and lower part. We told now about lower part of rectum and anal part or anal canal. Two parts. The most common metastasis spread laterally to perianal nodes and may appear in inguinal nodes. In these cases, if patient had anal cancer, of course you must palpate inguinal lymph node metastasis. If there are enlargement lymph node metastasis, it means regional metastasis, not distal metastasis. Why? Because the blood supplying from pudenda, if you remember, from pudenda, and through the pudenda, the first group lymph nodes metastasis will be in inguinal lymph nodes. But if the patient had anal cancer and the patient had metastasis in peritoneum, we can talk about stage 4. That means it is distal metastasis. And the same, if the localization in sigmoid colon, for example, and the patient had inguinal lymph node metastasis, it will be distant metastasis, not regional metastasis. You must understand these things because it's very important. Staging and antenym classification. There are two staging for colon cancer and for rectal anal canal cancer. T in situ in 0 M0 zero stage. First stage T1 in 0 M0. T1, what mean T1? T1 that the tumor invasive just to mucosa. T2 tumor invasive to muscular layer of bowel. T3 the tumor invasive to serosal layer. And T4 the tumor invasive to adjacent organs. No, as just now we told. For example, depending on localization of the tumor, descending part, for example, or ascending part, or liver angle, if it is invasive to liver, or transversus if invasive to stomach or to pancreas, depending on localization of the tumor. If the tumor invasive through the serosa to adjacent organs, it means T4. In 0, if there are no lymph node metastasis, and M0 if there are no lymph node, no distant metastasis. In 1, there are lymph node metastasis up to 3 metastasis. In 2, more than 3 lymph node metastasis. M1, if there are distant metastasis, and the most common in colorectal cancer, the first metastasis will be in the liver. And here, depending on our TNM classification, we put the stage. Stage 1, T1 in 0 M0, or T2 in 0 M0. Stage 2, T3 in 0 M0, or T4 in 0 M0. Stage 3, any T in 1 M0, or any T in 2 M0, divided stage 3 to stage 3A and stage 3B. Stage 4, any T, any N, M1 distant metastasis is present. Stage grouping for rectal anal canal cancer. T in situ in 0 M0, the 0 stage. T1 in 0 M0. T2 in 0 M0 to second stage, or T3 in 0 M0. And the same stage 3 divided to A and B. T1, 2, 3 in 1 M0, T4 in 1 M0. And stage 4, any T, any N, and distant metastasis. And here in anal canal, T4 to which organs? Maybe invasive to adjacent organs, to prostate, to perianal area, to cutaneous of perianal area, to depending on localization, lower part, for example, to vagina in woman, to prostate in men, or to gallbladder, urine bladder, excuse me, or to uterus. Clinical manifestation of colon cancer is divided into the period of latent current, the period of intestinal disturbance, the period of general disturbance. The main clinical forms are obstructive form, form with intoxication and anemia, or told toxic anemic form, dyspeptic form, pseudo-inflammatory form, enterocolitis form. But the pathogenomic signs of colorectal cancer are not present, is absent. Cancer symptoms. Iron deficiency, anemia, is often sign of the disease in right side of colon. And the same, you must know and remember one thing for all your life in the future, that if you see patient with anemia, there are three causes. The first causes is chronic anemia. We told about chronic anemia, not acute anemia. Chronic anemia, that you must do investigation, maybe hypochronic anemia, or tumor in right side of colon, or tumor in the stomach. Three causes, or blood disease, hypochronic anemia. In oncology, usually patient who had gastric cancer or cancer of right part of colon, the most common cecum and ascending part of colon, usually with complication of anemia, usually. But in the left part or left side of colon, the complication is not anemia, the complication is intestinal obstruction, and it is the most common size of cancer. In descending, in sigmoid part of colon, or in spleen angle part of colon. As we told that it is rarely very slowly growth, the patient usually after maybe 6 months or more or 1 year come already as emergency case with intestinal obstruction, usually before any signs. The first signs is intestinal obstruction. The most common symptom of cancer in ample of rectum is the stool with blood and mucous discharge. Predominating symptoms of cancer in anal part of rectum are severe pain during the defecation and tenesmus. Physical examination. The plan of objective examination of persons aged 40 and older with complaints of intestinal pains and constipation should include palpation of the lymph nodes in inguinal areas, digital rectum examination, gynecological examination in women. Physical examination, rectum cancer. In digital examination, there are rectum cancer. What you're feeling? The sessile polyp with ulceration, big ulcer with hard border, hard ring which does not pass a finger. No, here of course depending on size of the tumor. It is a standard. You must do digital investigation or examination. Diagnostic. Barium studies with or without eye contrast may be very helpful in establishing the diagnosis. No, we told about barium enema, or we told about erigoscopy or erigography, no, with barium enema. And as you see here in films, there are two localizations. The first localization is in cecum, and other localization in spleen angle, controlled. Colonoscopy. The helpful in evaluating the level of the tumor, the clinical signs of malignant degeneration of rectum polyps are appearance of the sessile polyp with ulceration. It's the first digital examination, palpation. Next, erigography or erigoscopy, barium enema. Next, colonoscopy, or we do for the first colonoscopy or erigography. Colonoscopy more good diagnostic than erigography. Why? Because through the colonoscopy we can take biopsy, which needed it at the future to put the final diagnosis for the patients. Other additional methods. Here we need it, for example, cystoscopy, depending if there are indication for cystoscopy. If you suspicion that the tumor invasive to urine bladder, or if the tumor localization is middle or lower part or rectosigmoid angle of the rectum, chest X-ray is necessary only for pre-synthetic evaluation. Chest X-ray, it is including as standard in diagnostics method. In diagnostics, we must do it. CT scan, or we can do CT scan for abdominal and thoracic. Usually the last time it's more better diagnostics method. CT scan of thoracic part, abdominal part, and pelvic. CT scan rarely indicated except for cases where the clinical sex to confirm clinical judgment of medical inoperability. It is other additional methods. Laboratory tests should include cancer embryogenic antigen CAA, an elevated cancer embryogenic antigen level pre-operatively suggests metastatic disease. Post-operative test, we do operation, after operation, or after our treatment, or after our radical treatment, should be obtained 1 or 2 months after treatment. Particularly here we told about surgery. A normal level is favorable sign. Elevated carcinoma embryogenic antigen strongly suggests acute residual disease. Differential diagnosis. In the older patient has blood and mucus in stool, it is necessary to make differential diagnostics either of colorectal cancer or hemorrhoid or dysentery. Cancer of rectum and ascending colon must be differentiated from appendicular infiltrate, anemia of the other reasons, tumor of the right kidney, retroperitoneal tumors, tuber ovarian cyst, or ovarian carcinoma in women. Cancer of the anal part of rectum must be differentiated from hemorrhoids and benign polyps. Principles of treatment. The mainly method of treatment in colorectal cancer is surgery, except anal canal. The mainly primary treatment is surgery, except anal canal. In anal canal, the primary method of treatment is chemical radiation therapy. Quality of life is improved even in the presence of distant metastasis. It means if the patient had just solitary metastasis or multiple metastasis, which can remove it, we removed it, even in the liver, in colorectal cancer. And it is improved. Pre or post-operative radiation therapy is beneficial in preventing local recurrence in rectal carcinoma after operation. The exact role of radiation plus chemotherapy as an adjuvant for rectal cancer is undergoing intensive clinical trials, but it appears very promising. What mean adjuvant therapy? If you remember, we explained what mean adjuvant therapy. When we told about adjuvant therapy, it means chemo or chemo radiation therapy in combination after surgical type of treatment. After. Yes, when we remove the tumor, after this patient need chemical chemio radiation therapy, depending on localization of the tumor. If the tumor in rectum, this patient needs chemical radiation therapy. If the tumor just in colon, after our operation, patients need adjuvant therapy, chemotherapy, just chemotherapy. In rectum cancer, chemo radiation therapy. In colon cancer, just chemotherapy. Surgical treatment. Polyps, precancerous disease, polyps, benign disease, should be evaluated with colonoscopy. Pedunculated, removable polyps should be resected through the colonoscopy. Malignant polyps with no evidence of stalk involvement and a clean line of resection require no additional therapy. If there is submucosal involvement or if the resection line is involved, then the risk of residual or recurrent disease are unacceptably high and further resection is indicated. Surgery is the primary treatment with resection of the segment of the involved intestine. Now, you see here margin of our resection. Margin of our resection. Depending on localization, cecum or liver angle as maximum, or if here ascending part of colon, the same operation, we must remove right side of colon, or we told right side hemicolectomy with lymph dissection or lymph dissection, our margin. Cancers of the colon are removed by a wide resection of the primary lesion together with all mesentery that contains lymph nodes. We must all group lymph nodes removed it here, our margin. And here we do with ileum, transverse ileum, here transverse anastomosis. For radical surgical treatment of cancer of ascending or descending part, the operation of hemicolectomy with intra-abdominal anastomosis is performed. If it is left side, we told spleen angle, descendant part, we do left side hemicolectomy with lymph dissection, and we do anastomosis, transverse sigmoid anastomosis. In transversus if the tumor localizes here, we do transversectomy with ascendance, descendance anastomosis. If the tumor localized on sigmoid part of colon, we do resection of sigma. And we do descendance rectum anastomosis. For operation, left side hemicolectomy, transversectomy, right side hemicolectomy, and sigmoidectomy with limb dissection. With intra-abdominal anastomosis. In sigmoidal and high rectal lesions, bowel resection with intra-abdominal anastomosis may be impossible. In these cases, it is necessary to make Gartmann's operation. The radical surgery with formation of artificial anus is in a proximal segment of colon after cancer removed. If it is here in this part in sigmoid, rectosigmoid junction, or a rectum, depending if the patient having intestinal obstruction, we can do anastomosis. But if the patient had acute intestinal obstruction, of course we do Hartmann operation. What mean Hartmann operation? Hartmann operation, it means when we remove the tumor, usually in left part. If you remember, we told about mechanisms. Left part usually give the first complication is obstruction. If it is acute obstruction, we remove the tumor, and the other end we do artificial anus. If it is acute intestinal obstruction. If there are no obstruction, we can do anastomosis. But if the patient had acute intestinal obstruction, it is contraindication to do anastomosis, because after 2 days after operation, the first complication will failure of anastomosis. It is contraindication in acute intestinal obstruction. We remove the tumor, we do artificial anus, and after 6 months we can do anastomosis. Close the artificial anus and do anastomosis. Laparoscopic colectomy is minimally invasive new technique. The procedure consists of mobilizing the colon laparoscopically and performing an extracorporeal anastomosis. In some situations, especially in the low sigmoid colon, an intracorporeal anastomosis can be performed. Now, the last time, the most common, we do laparoscopic colectomy. Not colectomy, it means right side hemicolectomy, or laparoscopic left side hemicolectomy, or laparoscopic resection of sigmoid part of colon. In lower rectal lesions, an abdominal perianal resection may be necessary. The operation is named in rectosigmoid junction. Tumor of rectosigmoid junction. The name of operation is intra or abdominal perianal resection. Local excisional of rectal cancer helps to avoid colostomy for well-differentiated lesions less than 3 cm in size. And if the localization in lower part of rectum, here we must do extirpation of rectum with artificial anus. Radiation therapy. Patients whose tumor lie within 15 cm from the anal verge and go through the bowel wall or involve regional lymph nodes are benefited by post-operative adjuvant radiation therapy. As just now we told that radiation therapy, all patients which had tumor in rectum, the lower part of rectum, middle part, and upper part of rectum, or we can told from anal 15 centimeters from anal. More than 15 centimeter localization of the tumor, we don't give radiation therapy, just chemotherapy. Less than 15 centimeters, we give radiation chemotherapy. Preoperative therapy use would also involve treating many patients unnecessary. Chemotherapy is carried out after radical surgery in case of metastatic spread into regional lymph nodes, stage 2 to 3. Stage 1, we don't give chemotherapy. Just begin from stage 2 and 3 and 4 stage. Anal cancer seems to respond well to radiation and 5-taururstil plus metamycin chemotherapy. The overall 5-year survival for colorectal cancer is 52%. However, when the disease is diagnosed in a localized stage, survival is up to 84%. Survival rates for colon cancer is 54% in recent years. Rectal cancer survival rate is 37 to up to 52%. So thank you very much. Thank you. Goodbye. See you next time.